Good morning. Welcome. Just for information purposes, this is session A4. And we still have a few people coming in, so with respect to those of you who have shown up on time and our speakers, we don't want to deter any longer from starting. So we'll just tolerate a bit of noise as the rest of the crowds trundle in. I'm Bob Lloyd, Executive Director at IHI, and want to welcome you to the forum and also to this, the first of the workshops. With me today for this session are three friends, Jonathan Bamber, Maxine Power, and Brian Bjorn. And they'll introduce their associations and affiliations as each of them gives their talk. The way we're going to organize this is that each one is going to spend about 15 to 20 minutes making their formal presentation. Once they're all done, we'll then entertain questions. And we have two colleagues with us, Lizzie and Kate. They are our Twitter gods. They are the keepers of the tweets, and the hashtag for this session is #Quality4. If you wish to make comments, they will be monitoring it, and if there's anyone who has questions or connectivity problems, please raise your hand and we'll scoot over. They also will be assisting me at the end in managing our questions. If any of you do want to stay afterwards, because lunch will be right afterwards, we will entertain further questions, but at the end of the session, if you need to go on to a next meeting or to lunch, please feel free to leave, and those that want to stay, please come to the front and we'll have further dialogue and Q&A. All right? Very good. Without further ado, let me introduce and start with Jonathan, who will kick us off.
Thank you. Good morning. My name's Jonathan Bamber and I work for the Health Foundation. For those who don't know our organisation, we are a completely independent charity that works to improve the quality of healthcare within the UK. We're lucky enough to be in a position to spend about £25 to £30 million a year on this endeavour. Today I'm going to be introducing a potentially groundbreaking report that Professor Vincent and colleagues from Imperial College London have written for us. I'm going to be concentrating mainly on a framework within this report which provides key dimensions for a safe system. And I'm also going to be asking for your help to get involved in a conversation around how we take this work forward. Within the NHS and globally, we do a lot of measuring around safety. But if we were going to ask ourselves the question, are patients any safer than they were 10 years ago, there are a few of us in this room who'd be able to answer that question. There are different reasons for that. There are different facets and different perspectives to how we could be approaching this problem. Should we be focusing on harm, on error, reliability, resilience, or other indices? Another challenge is that over the last decade, much of our focus in safety measurement has been around how harmful our systems are, not on how safe our systems are. At the Health Foundation, we're taking the stance that we need to look at how we can enable safety to be actively managed by healthcare professionals and patients. So we thought we'd have a little bit of a further look at measuring and monitoring. And back in 2011, when Dr. Jane Jones and I looked at commissioning this work, we thought that the time was right to pull together all of the current measurement approaches, metrics and tools into one clear picture, look at ways that different mechanisms and approaches could be used within healthcare, and then to positively illustrate a potential future direction. And this led to this report. So this report is being fully launched next Wednesday on the 24th of April, but we have hard copies of this report available at our Health Foundation stand, which is next to the registration room in the main concourse. When we commissioned this, we got these three people to do the work for us. So this is Professor Charles Vincent, Susan Burnett, and Dr. Jane Carthy from Imperial College London. Now they looked at a range of literature reviews, interviews with senior staff across the UK of national organisations, and carried out 11 detailed case studies of healthcare organisations within the UK and the United States. And we tasked them to look at this question: how do we know care is safe? And the researchers then broke this question down into a range of questions, which you can see here on the slides. Just going to pause for a second for you to have a look at those questions. Now, they then developed these questions into a framework of 5 dimensions: past harm, how reliable our clinical systems and processes are, how sensitive we are to when things go wrong, how able we are to be able to monitor that, reflect on that, and act upon that. Now, interestingly, this phrase, sensitivity to operations, comes from other safety critical industries. And the language that's often used for this is the sensitivity of high reliability organisations of their staff of changes to operations. Now, we know from major incidents into failure within healthcare that invariably it's the patients, the families, the carers who are the main trigger for making sure that problems and failures come to the attention and get dealt with. And perhaps we should be looking a little bit more into that role of its staff, patients and carers. But I digress slightly. Fourthly, we have, will our care be safe in the future? And lastly, are we responding to and improving from the information that we have together? And I'm going to spend a couple of minutes on this slide and make 3 main points. The first is that there are different ways that you could be looking at this safe system, and we're not saying this is the only way that you could outline this information. However, I believe that the researchers have managed to balance the importance of providing clarity and simplicity for this to be a framework for different audiences to engage in, while at the same time not oversimplifying a complicated situation. The second thing I'd say is that we're not just talking here about the tools and metrics to measure safety. Comparable weight needs to be given to our ability to monitor, reflect, and learn upon safety. Now, the researchers within the reports spend some time going into detail on each of these 5 dimensions, looking at what measures are currently available, what approaches and mechanisms there are that could potentially be used within healthcare, are used in different areas of healthcare or outside of healthcare, outlining what some of the main challenges are within each of these dimensions, and then putting forward some suggestions of a way forward that could be taken in discussion. And the third point I was going to make is that across these 5 dimensions, there are different levels of development that the researchers concluded on each dimension. For example, there's considerable work that has been considerable work and focus into past harms, whereas the researchers found that anticipation and preparedness was a dimension that was least developed. So I'm now going to go into some detail on a couple of these dimensions, one that has had some considerable focus, reliability, and a second one learning and integration, which perhaps should have more. So reliability. This is defined as failure-free operation over time. And it's perhaps worth us spending a little bit of time looking into the different types of reliability. So there's reliability you can have on a particular mechanism or tool, on how reliable that is. Is the bike that I cycle to work in going to be reliable? Are there particular instruments within surgery that are reliable? There's also the reliability of behaviour. When I ride my bike, will I be wearing my helmet? Will I remember not to cut inside lorries on the inside? And behaviour within healthcare, we can look at compliance with hand hygiene, for example. There's also a third aspect of reliability, which is the reliability of systems and whole processes. Now, this is where my bicycle analogy falls down somewhat, but within healthcare, you can be looking at particular critical processes such as the handover between different parts of an organisation or between organisations, or the handover of staff between a day ward and a night ward. Now, focus on reliability has shown that there are variable rates in the reliability within healthcare. It's a piece of work that I commissioned Brian E. Dean Franklin and Susan Burnett and colleagues to carry out a few years ago, which looked into 4 critical processes in the UK across 7 different locations and found an average reliability rate of between 81 and 87%. And that translates into between 13 and 19% of the time those processes failed. And the connection here between reliability and safety can be seen in one of those examples of the availability of clinical information in outpatients' appointments. And the researchers found that in 15% of times, critical information was missing from those records. And the healthcare professionals involved estimated that in 6% of those occasions there was a direct exposure to risk. So the researchers found that there was much done in reliability and isolation, but perhaps one of the biggest challenges, and I think this is something that Maureen touched on in the keynote session, is around providing whole system reliability. And perhaps a next step could be to identify safety critical processes across a whole system, and importantly, identify the levels expected, the minimum levels of reliability within those processes. And although this sounds relatively simple or basic, this would be a massive step forward. Turning to integration and learning. Now, in many ways, this could be seen as drawing together the information contained within the previous 4 dimensions. And a lot of focus within organisations and trusts is given to this difficult question of how you integrate the wealth of information that is available to us in a meaningful way. This is tricky. This is further complicated by the need that in different levels of a system, you're going to have different needs, different information that you're going to be wanting to integrate together. There's also an aspect of you needing different information at different times, and how timely that information is for you to be able to act to make a difference. But we're not just talking about integration here, and it's perhaps understandable that people have been focusing resources on integration because of that complexity. But there is a need also to analyse, learn, provide feedback and take action upon that information. And perhaps the next step would be for us to be focusing on what approaches we can pull together to aid this analysis and learning. I'm going to touch on a couple of examples here that came out of the report as illustrations, and not as necessarily gold standard things which should be taken forward, but just an illustration of where we're at the moment. So the first is an example of learning newsletters from a mental health trust, and the second is an annual learning report, so focusing on particular themes that are analysed across an organisation. This comes from a community care trust and fed back to different teams. Now my take on this is that it's important that this information is locally adapted, relevant for particular audiences, but also that it's not a one-way process. You have people sitting on one side saying, this is what we need to be learning and changing, and then it's just provided. It needs to be a two-way process. The third example I'm going to mention briefly is the concept of safety cases. And for those who are involved in other safety critical industries, this will be a process that would be familiar to you. A safety case is pulling together all the available evidence to make a structured argument of the reliability and safety of a particular process or mechanism. For example, a radar system within aviation. Now, the important aspects that I'm mentioning here relating to integration and learning is that once these systems are set up, that you're saying on balance we're managing the risk and we think that this process, this set of processes should be following this minimum levels of safety and managing risk appropriately. The important aspect is that this needs to be an ongoing case that is constantly updated. Now I should state here that these three examples are just illustrative, and much more work is needed on working through how you can have a learning system. And it was interesting in the keynote session this morning, the example of North Shore that Maureen pulled out of having integrated systems for a whole population in order for you to quickly make decisions, to anticipate and learn. So before wrapping up, I'd like to turn to the full framework again and ask the question for you: is your organisation's main focus on past harm, or have you within your organisation got a broader approach? And perhaps more importantly, is there a disconnect between the dimensions that you think are a priority to be focusing on to answer this question, how we know care is safe? Is there a disconnect between those priorities and where you actually spend your time and resources? So my reflections are that this framework encompasses the key components of a safe system. However, we recognise that consideration needs to be taken into how to make this work into practical tools to be used locally. We recognise that life gets in the way. I was speaking to someone yesterday who was saying, all this enthusiasm on quality improvement that I keep on coming across keeps on bashing against my cynicism, or my cynicism that I don't want to have. This is this person talking. Because the reality within the NHS, and I'm sure other health systems, is that it's all about costs, resources and costs. So any focus on answering this question needs to take that into consideration. And anyone who knows me will smile on the fact that I mentioned that it's all about context. This is something that I've been going on about for years. And different contexts will need to be taken into consideration. So the Health Foundation recognised that there's a need to adapt and customise this information to different audiences and settings. And in particular, there's likely to be different approaches you'd be taking looking at an organisation compared to if you were going to look at an entire patient pathway, or you were going to look at the safety of an entire population. So this is going to be the main focus, or one of the main focuses for the Health Foundation for the next couple of years, around measurement and monitoring. And the stage we're at the moment is that we need the help from stakeholders like yourselves to get involved in a conversation with us over whether this framework resonates, if you have examples of good practice, how you think this would be useful in your particular local setting. We're having this consultation that starts on the 24th of April, and you can access that information on the website you see on the screen here. And please feel free to come and talk to myself or the authors in breaks. So finally, to finish, I'd like to thank all of the researchers in particular, and Professor Charles Vincent and Susan Burnett are in the audience today, and so if we have time for questions later, they'd be available to answer questions as well, and also the advisory board for this work, who have been very supportive. Thank you.